Hey, good afternoon, everyone. Thank you so much for joining the Center for the Study of Race, Politics, and Culture, or CSRPC, for our second Research Bites of the year. My name is Anaga Dalal, and I am Assistant Director for Communications at the Center. So, Research Bites is our monthly speaker series that is one of many programs that CSRPC has produced over our almost 30 years of engaging scholars, students, staff, and community members in our core mission to advance scholarship, arts, and public dialogue about the centrality of race and racism in the systems we inhabit. A huge thank you to CSRPC Program Administrator Tiara Kilpatrick, who spearheads this amazing program. Our goal for this series is to create an informal and interactive space where we all can learn firsthand about some of the exciting research happening on the University of Chicago campus. We hope you will use this hour to share your interests with each other and explore possibilities for future collaboration. Please watch the chat for subscription links for upcoming research bites, as well as for The Hub, which is our weekly newsletter. I also want to encourage you to follow us on social media. Our handle is at CSRPC. Today, I am excited to introduce our featured speaker, Marcia Tan, who is an assistant professor in the Department of Public Health Sciences. Dr. Tan is a health psychologist and epidemiologist who focuses on reducing health disparities among underserved populations through health behavior change. Her research interests include examining biopsychosocial and behavioral factors that contribute to disparities in chronic disease, such as cancer. She also conducts community-based health behavior interventions to reduce risk factors among disparate populations. A majority of her work has focused on tobacco cessation and weight management among low-income, racial, and ethnic minority populations. And now I invite you to join me with a warm welcome to Professor Tan.
Thank you very much. I am going to share some slides. Okay, is that good? Everyone can see
Yes,
that.
we can
Okay.
see.
Um, okay, let's get my little windows here. Okay, thank you so much for having me. Thank you for the introduction. I'll introduce myself a little bit more in a second. But again, my name is Marcia Tan. I'm in public health sciences. I'm also the Assistant Director of Community Outreach and Engagement at the Cancer Center. And I'm happy to share my research with you today. Quick little overview of what I'll be talking about. I'm going to introduce my research area, but also who community health workers are, because I'll be talking about this workforce for today, and then I'll describe a current research study that I have. And then, hopefully if we have some time at the end, I'll do kind of like the larger research overview of all of the studies that I have going on in my lab, which is a lot. So just, I've heard that, baby pictures are welcomed here. So this is my time to show you me as a child. So here's this is me, a little chubby arms over there. So I actually was a very, very quiet child, very, very shy. It's confusing to people who know me right now. And I was a dancer, a gymnast when I was little. I was very active. And I also was very afraid of Santa Claus, but I always had to take this picture every year. Um, and also, in thinking about baby pictures, I really have to show, pictures of my babies too. And so, this is me as maybe like 18-month-old, I think maybe 2 years old. My sister said I would never grow into my ears, but I did. And then I married a man, and this is his baby picture. His name is Jimmy. And I love this so much because this suit really it just really it's amazing. He did grow up to be a good dresser as well. So together, we made these two babies. So these are my kids as babies. Joshua on the left, he's my oldest, and Johnny on the right, who is my youngest. And this is them now. This actually was them last week. Johnny's 4 now, and Josh is 7. They love to play make-believe. They're building a house within our house right now. Although my 4-year-old frequently tells me that she wants me to sell our house, and because she wants a different house right now. And then this is like the one only picture that I have of them actually smiling at the camera because they usually look like this when they take pictures. So every picture I have of them is usually them making some kind of face. And I also think about my family, I have to give like the larger, picture of my larger family. And I am the middle. I call myself the fake middle child because my little sister is 12 years younger than me. So I was I was the youngest for about 12 years, and then she came along. But my little sister's here, and my big sister has two kids. These are my nieces. And my mom and my dad from Alabama. I live in Alabama now. And I want to present this and show my family. We're very close. Actually, I'll be seeing them in a few days. And thinking about my career journey, it really started with my mom, who's a cancer nurse. So she's worked in like overnight for 30 plus years in oncology service as a nurse. And from that, I only knew about medicine. And so I knew that as I grew up, I really liked the idea of health and keeping people healthy, but only knowing that about medicine. And so I was like, okay, maybe I should just go, be a doctor. And then I realized, well, very shortly, early on in my college career, I, did an internship at a hospital, and I was like, I do not want to be a doctor, but I still had this like kind of health focus. And I took my first intro to psychology class, and that's when I took that class, I realized like, oh, human behavior is what I really love. Like, and I really like thinking about behavior in psychology because, you know, human beings are both the same but different, right? So I think, we connect and on the fact that we are humans, we all need sleep, we all need, food to survive, and we all express these basic emotions. But we are very different in how we express those things and how, the context in which we, express those emotions and just our lives and ourselves. And I like this, the color wheel of feelings is kind of a good example of, we have these 4 to 6, depending on who you ask, basic emotions, but the expression of them can be so different depending on who you're talking to in the context. And so this is what we call the dialectical in psychology of like the existence of two opposites, humans being the exact same but very different. And so I kind of started on my journey as a psychologist, from that intro to psych class that I took. But still, and this is my, background of my general, training. I am from Alabama, born and raised. I went to University of Alabama for undergrad, and I got a degree in psychology. Still graduating from college, I didn't know what I wanted to do, so I worked 3 part-time jobs. One at Smoothie King, that was the best job, so I got a free smoothie cup every day. And then I went into public health because somebody suggested it. And I got a degree in epidemiology, understanding, looking at disease and the pattern of disease and kind of population health over time. But at that time, when I was in public health school, I didn't think that mental health was on the public health agenda as much as it really needed to be. And so I was like, I think I wanted to explore more about mental health, behavior, things like that. And so I ended up getting a degree in clinical health psychology. And that's why I'm equally trained as a clinician, like as a therapist, and also as a researcher um, doing health psychology research, which is like behavioral science. And then from that, I moved to Chicago, got my PhD. Sorry, I moved to Chicago for a postdoc at Northwestern in cancer prevention and control. So I started work in tobacco cessation at University of Miami, and clinically, I've worked with hundreds of people who are trying to quit smoking cigarettes or use tobacco. And I really kind of fell in love with the work and really understanding like what a big need there still is for that. And then so I kind of, started my, career trajectory in this content area of tobacco cessation and control. And I've kind of entered the cancer space, although tobacco is, relevant to many different chronic conditions, not just cancer. So just to kind of set this to tone for what drives my work and kind of why I'm here studying what I'm doing. Um, I do a lot of work, on trying to still understand health disparities, reduce them, improve health equity. And I always present this chart, and this chart comes from the National Institute of Minority Health and Health Disparities. And this is a chart for researchers, and it's to kind of help encourage how we should be thinking about doing research in health disparities. And the point of this chart to display it is to show just how complex the issue of health disparities are in our country. But to note that, the way that we're trained, like me as a psychologist, for instance, we really are trained in like one little box. Like I did a lot of training to understand behavioral interventions and how to help people quit smoking or lose weight or sleep better. But there's so many other levels and like domains that impact and sustain disparities. And we really are charged as researchers to think about doing research that cut across multiple levels of influence as well as multiple domains of influence, and how this is really the only approach that we can take to work on this problem. And so again, like I've really been here at the individual level, thinking about the individual, but now I'm trying to really expand and think about the community level and how community influences disparities or maintains and sustains disparities, but also how we can think about intervening at the community level to improve the health of individuals. And so, thinking about tobacco use, something that's always struck me is that, we've seen this chart like in public health school and class about how, tobacco use has declined steadily over time. So ever since 1964, when the Surgeon General report came out that said smoking causes cancer, you start to see a lot of public health efforts and campaigns around helping people quit smoking, and you did see this decline, and the incidence of smoking and people picking up smoking for the first time decreased over time too. And so, you see this nice trend down that's consistently still been going down. We kind of consider this our public health win. But unfortunately, that is not the case for everybody. So if you look at certain subgroups of people, like people with low education, LGBTQ plus populations, even people living in the Midwest, you don't see that same decline. You kind of see, more of a plateau over time or even sustained rates over time for certain groups. And I've always been struck by this of like, who are we missing? Who are we leaving behind? If we look at these aggregate overall trends, then we see this decline, but when you actually break it apart, you have a completely different story depending on who you're working with. And then, to orient everyone, when I'm usually in person, I ask people like, how many people know somebody who has smoked before or quit smoking? And usually everybody says that. And then, or I ask like, how many people who knew someone who tried to quit smoking, it was really hard for them. They had to try a few times. Most people will raise their hands. And, to kind of, orient us to why is it so difficult to quit smoking, you might have heard that it's hard to actually put down cigarettes or other tobacco products, is that we often talk about the risk factor of the behavior of smoking and like really working on helping people quit smoking, but we less often talk about the upstream factors that are sustaining smoking in the first place for people. And so we again thinking about disparities, we thinking about the actual like risk factors, but we really need to start thinking about the inequities that lead to those conditions that causes those disparities. For tobacco's use, it's sadly like a very clear kind of like linear pathway of the tobacco industry targeting Black and Brown communities to smoke specifically menthol cigarettes, then marketing and advertising menthol for those communities, thinking about redlining and segregated communities, so having concentrated areas of tobacco advertising, concentrated areas of availability of cigarettes, for certain groups. And then so therefore you end up seeing these high rates within certain communities of smoking, but then also you see a lot of intergenerational smoking where younger kids have access to cigarettes because everybody in their household, the adults in the household are smoking, and it kind of is this perpetuated over time. And so what I'm interested in again is thinking about moving upstream and what are we thinking, how are we acknowledging and addressing some of these upstream factors that are creating these disparities in smoking and also and the difficulties around quitting smoking. And so I've been really interested in like the living environment and kind of, the access that people have. And we've been working on smoking cessation for decades. We have a lot of, effective interventions to help people quit smoking, like therapies, medications, all of those things. But there's still a good number of people who don't have access to these interventions, who aren't, getting advised to quit smoking, or, having, providers like help people with quitting smoking, or giving them resources. So I actually started a project in 2017 at my during my postdoc at Northwestern, where I went to a community symposium. It was on cancer health disparities, and I met someone from the American Lung Association. And they were tobacco control specialists there, that they were saying that some of the community health workers who um, contacted them, they really wanted to get trained on how to help other people quit smoking. So the community members they were working with, they really wanted to get trained on how to help people quit smoking. But the resources that the American Lung Association had were too expensive, and they were too expensive for them, and also the trainings were too long. They could never, take off work or not work for 8 hours a day to get this training, and also it wouldn't get reimbursed. So they were like, "What can you do? What do you have available that's shorter, or something that we can access?" And these were community health workers. And community health workers, the way that we usually describe them, are, the bridge between the healthcare system and community members. And they really are a link between, kind of bringing the community, bringing health services to the community. And this is the official definition from the American Public Health Association, where CHWs are frontline public health workers that really facilitate access to services and improve quality and cultural competence of service delivery. Now, this role of community health workers, so community health workers have existed across the globe for decades and decades and decades. It's a very grassroots movement to really reach people who are out in rural settings, often who don't have access to like clinic, based care and other healthcare services. But the role of community health workers was officially recognized as part of the healthcare workforce just in 2010 under the Affordable Care Act. And but even still, this model of a CHW has really been found to be effective, and really effective for across a lot of different healthcare services. So in the U.S., I will say many community health workers have been, deployed in the areas of diabetes prevention, asthma, heart disease prevention, like broadly chronic disease prevention. But there are other, services like maternal and child health, and mental health, and infectious disease that community health workers really have been working in. So this model has been established, but it is very variable. So kind of depending on where they're working, who they're working with, it's kind of depend on, kind of what, chronic disease topic, or what disease topic they'll be working on. And so, so from working with the American Lung Association, I, was kind of start to learn more about community health workers as a workforce, and is really thinking about, how important they are to really respond to the needs of community members and patients. And so they really are designed, and we think about all of the social determinants of health. So, all of the things that, like, transportation issues, food insecurity. They really were like helping patients get what they need in order to create that space for people to attend appointments or receive health care. And so, if you look on the left here, this is Mary in the yellow shirt. So let's say Mary uses, tobacco, smokes cigarettes. Maybe a standard intervention might be her to go to the clinic or go to the hospital to go to like a tobacco cessation session, like one time or once a week for 8 weeks. But then, the problem is that she still goes back home, and there's all of these triggers and all of these, her environment that kind of, will trigger and kind of sustain that smoking over time. A community health worker, for instance, will meet Mary where she is and where she needs to be. So she might meet her at her house, her church, her grandchild's school, and really has this continuous, flexible relationship with Mary. So for the rationale for the project that I'm going to discuss now is really, if they already are meeting people where they are, already are responding to their needs, how do we build capacity in CHWs, how do we provide them with the knowledge and the skills that they need to help people, connect people to resources for quitting smoking or help them directly, counsel them to quit smoking themselves. Um, and so, my project, which is my general title of my talk, developing a tobacco cessation curriculum for community health workers. The general overview is that, trying to trying to address this problem that a lot of people who lived in low resource communities don't receive help quitting. And so even if they do go to the doctor, so many people don't have regular access to like a primary care physician or do a primary care appointment. Even if they do go to the doctor, doctors often don't advise people to quit smoking or even address tobacco because there are probably other concerns that they're thinking about there. So there is this like gap in access, not just physical access, but also even when you're there at the doctor. And so we designed a program specifically for community health workers, to help people quit and connect them to services. And what I'm going to present to you today is, kind of the result of the effectiveness of this program on actually increasing knowledge and confidence and readiness of the community health workers to do brief counseling for tobacco. I'm going to go through that now. But first, I want to, say hello to my wonderful lab who has helped with this project over time. And this has been a 7-year project and still ongoing. And this project I always refer to as a community engaged research project. And just to give a little background about community engaged research, sometimes people use these terms like interchangeably, but this is kind of a nice spectrum to kind of show the involvement of community and research on the low end to the high end. And on the low end really is the investigator-driven research. And this is really how many researchers in classic like academic settings are trained to kind of come up with the research question yourself, design your study, collect your data, figure out your results, and then you should publish them or, disseminate them however. But what we really are moving towards is really having the community members, the community themselves in charge of that research, right? So the next step is community-based research where there might be, again, an investigator or a scientist who develops their own question, but then might do that research in the community somehow. But again, the community is really just kind of, part of like the methods or the collection of data. Community engaged is somewhere in the middle where there is involvement of the community, where there is influence on how the research is being conducted or designed, but not fully for the community, from the community. And then when we start moving towards the other end of the spectrum, then what you might have heard of is community-based participatory research, where the community themselves are, with still usually with this academic partnership, is designing research question, has more involvement, more power in how the research is going to be conducted, having ownership of the results, having a say in how the research is going to be disseminated. But kind of like the ideal is really kind of moving toward the community-driven side, where the community themselves are assessing what the research question is, assessing the problem, and having the resources and the capacity to actually collect data, themselves and develop the research and collect and disseminate the information. I would say my project is probably in this pink area, like kind of in the middle of community engaged. And so this is a very busy circle. I call this the colorful circle to describe my steps in developing this program. You don't have to look at it too closely, but we use this model that's an implementation science model and also this business model to develop this project like an iteration. So we kind of started off a little bit, and I'll kind of go through examples of how we did that to really adapt a program to be specific to how community health workers see patients and to be specific to their context. And then we also, along the way, we partnered with and incorporated community health worker feedback at each phase of the development, which is very important. And I'll talk about why in a second. So for the first phase, what we call the exploration phase, this is the where we did the needs assessment. So when I started this project, I was just like, okay, we have so much tobacco stuff that exists. Do we actually really need to develop something different or adapt something new for this population? And so we started off with a needs assessment survey that was about 45 questions. Importantly, it was reviewed by 2 community health workers that we had take the survey. And from that, we redesigned and rewrote like most of the questions that we had on the survey, because the first iteration we had just did not work for them. And actually one of them stopped taking the survey halfway through, and she was just like, I can't finish this survey because I don't understand what you're asking me. And so that was very important, lesson for us because, like, based on my training, I'm like, this is survey development. And they were just like, no, this is not going to be useful. So we redesigned the survey, we distributed it, we translated to Spanish as well, and updated some information to be specific to Spanish speaking populations. And we got about 54 respondents in both English and Spanish from the survey. What we found is, I know this is a blurry, but if you kind of note the bars, that there was a lack of knowledge about tobacco cessation, tobacco use, and treatments for tobacco. So there was this knowledge gap in understanding, the issue of tobacco and tobacco use in the communities that they were working with. So we were like, okay, well, there is this knowledge gap. Like, what do we do with that? And then next, we followed up with a focus group based on some of the survey questions and answers that were received to talk to some community health workers about just kind of their practice with tobacco cessation, their knowledge about it, what they would want if we did develop a training for them. And then some of the main things that we found is that there's a lot of flexibility in how they see patients. So it's not just, they have one session, one time, or they like follow up this number of times. They're just like, it really depends. Like I might go in one day and help. Somebody told a story about like one day I went in and helped somebody fix their thermostat for an hour and a half, and that was our session for the day. And then the next time I went back, then we kind of talked about asthma, and then we kind of talked about these things, and they really were like very. It was very important for them to note that they care about how much their patients and their community members are dealing with, right? So it's not that they're like, sometimes I don't feel comfortable going in and talking about what I planned on talking about because they might just need to talk about what just happened to them, that day before, right? And so they really are flexible and responsive. And then so therefore it's variable of where they see patients, the number of sessions they have, and also just really kind of like the way that we design tobacco cessation programs really aren't a good fit for their model because oftentimes it's not just tobacco use, it's like all the other things, right? So how can you just think about tobacco as a standalone thing without connecting it to everything else that's going on in their lives? And so, quote here, but we do it in steps. They're not bombarded all at once with everything. It's like in pieces. Again, they're really taking care of, how overwhelmed some of the people are they're working with, and how to really think about how to effectively help them and be there and support them along the way. Next, we did the preparation phase was actually like developing this intervention. So from our needs assessment, we realized that there was a knowledge gap. From the focus groups, there was a need to kind of adapt what we already have currently for tobacco cessation for this specific group of community health workers, both for the way that they see patients, but also for the types of the patients that they see too. And a lot of the material that we have for tobacco cessation is very standard. It's like, if you are, craving a cigarette or you have an urge to smoke, just go, take a walk outside, or, it's like things like that. And it's like, well, what if someone can't walk outside, their door, maybe it's not safe, or like, oh, go call a friend. It's like, well, what if, someone doesn't have access to a phone at that moment, right? And so they were like, there isn't a space to adapt something that is specific to who they see as well. So we use this program, which is from the WHO, which is called the Toolkit for Delivering the 5 A's and 5 R's, Brief Tobacco Interventions in Primary Care. So it's designed for people in primary care to do brief counseling, which is around like asking people if they smoke, advising them to quit, assessing their motivation to quit, and then assisting them with that quit process and following up with them. And so what we did is we took this, we developed an outline of what we would put in a training. And so as far as the content area, but also like what a training would look like, how long would it be, like what we would cover, and things like that. And then we ran this by CHW. So this is what's called an agile science approach. So instead of fully creating the program, we created a piece of the program, got feedback from it to further like create it over time. And so what we found is like from these focus groups, so we had an outline of the training and also sample PowerPoint slides. And there were four main themes that came up. And one was that, smoking is a stress reliever for many of the people that they work with. And they were very adamant about if we're going to remove their main coping mechanism by trying to help them quit smoking, we have to replace that with something else, right? And then next, the idea of like personalizing it to the other health needs. So it's not just they're not just using tobacco. They have, heart disease, they have diabetes, they have other things they're dealing with, and how do we connect, the smoking with all of those other things too. And as far as, the skills that the CHWs wanted, they really talked about how they really wanted to learn how to motivate their patients because they were like, most of the people that we work with, first of all, they were like 99% of the people that we work with smoke. And we were like, okay, well, that's like all of them. So like, what's the real number? There's no, they were like, everybody smokes. And we were like, okay, well, if you had to do a percentage, what would you say? They were like 99%. So everybody. And so, but they were like, but most people have either tried, quitting before, it's just too overwhelming. And they were like, well, what do we do? How do we motivate and like maintain that motivation for them to prioritize this, like for their health goals? And then last, they talked about really wanting key language. Like, how do you respond? We hear these same things over and over again. Like, how do you respond when people aren't ready to quit? We need role playing examples. We need to actually build these skills. And so this was like, something we really identified, like the mismatch of what we were planning on doing, which was to do this like brief counseling intervention where you assume that people kind of are ready to quit and it's really about assisting them with quitting. And we had to kind of reconfigure it and kind of go back to just motivate, like straight motivation. Like how do you motivate people to quit? And how do you get people to understand how smoking is related to, their health goals or not? And as an example, I want you to give me some talking points. The client said, no, they're not ready to quit. Okay, they already shared with me that they already know the dangers of smoking. They're just not ready to stop smoking. That's why I want you to give me some talking points. So it's really not about educating like, oh, smoking's bad for you. We're past that point, right? It's kind of like, how do I like actually kind of like move the conversation along to talk about this in the context of everything else that's going on for them. So from the focus group data, we developed the curriculum, which is called the Change. So again, we use this WHO as a baseline, and then we updated it according to the information that we got from our conversations with the CHWs. And then once we came up with a PowerPoint and some handouts, we consulted with a group called Crowd, which is based out of Sinai Urban Health Institute on the west side to get feedback, and this is a CHW Training Institute. So we got feedback on the curriculum PowerPoint, and they gave us some good tips. As an example of the outline that we have, and they really talked about highlighting when things were talking points with the clients versus not, versus information for them just to know and things like that. And it was really helpful to kind of think about, again, like how the CHWs are interacting with the patients. So, for example, we created new content to address these comorbidities that patients have. So, like, we connected it to everything else that they might be going through. So, we have like 11 different ones, like tobacco and diabetes, tobacco and heart disease, with like bottom line, like take home points. We have tobacco and HIV, tobacco cancer, tobacco and pregnancy, tobacco and weight, COVID-19, all of the things that, the things that their patients are dealing with. And then we, kind of how showed that nice little graph in the beginning. We deleted all of that information because they were like, we don't need to know the rates of whatever. We know it's bad. Like, let's move on. And we really talked a lot about tobacco industry's targeting of these populations. That's because they were like, that stuff we don't know. And that's stuff that, our community needs to know about, like how this was all the strategic process to get us to like have this problem in the first place. And so we talked a lot about the intergenerational nature of it, why that is like happening, how the tobacco industry is targeting. And then we brought up things that were relevant, like tobacco use and marijuana, because most people are not just smoking a cigarette. Like, people are, there's a lot of co-use of marijuana. Every single focus group that we did, somebody brought up marijuana and we had a whole discussion about marijuana. So we wanted to like bring that in because these were things that were relevant to their patients. And then we talked about, and then we also, I don't know if I said, so we also had the case studies like to go along the way to really talk about things to contextualize things for people. And they were like, we always say like, oh, who knows a Sean? Like Sean, says he's not ready to quit, but he smokes, marijuana and cigarettes every day. And everybody's like raising their hand, so we tried to do it so they can like put everything in perspective, all the information that they were learning. And then we also had a booklet on motivational interviewing responses, so ways that they can like respond to patients to kind of keep the conversation going to help motivate their patients. And importantly, we had a phrases to avoid section. And I always describe this as these are all the things that we want to say to people, but we know that if we say it, it's not going to help the conversation keep going. And then, so once we developed the training, then we pilot tested it. So the next phase, which we're kind of in this implementation phase right now, is that so now we've trained maybe like 130 community health workers in the Chicagoland area over the past 2 years, which has been nice. We've had several trainings, maybe like 8 to 10 trainings so far. And these have been CHWs who've worked in nonprofit organizations. Some have been associated with hospital systems, some that were in community health worker programs, like associate degree programs and community colleges. So we've had a wide range of CHWs over time. And what we're learning too now is the context in which they work does matter too, as far as thinking about the role playing and kind of, I think we realized like over time, there's an assumption in our training of like how often they'll be seeing, their community members and things like that. So we learned that, there's some people who work for the Department of Public Health that were like, we have like 30-second conversations with people as opposed to like sitting with them for an hour. So like, what can we say in these like 30-second sound bites to connect them to resources? So we're trying to like kind of redevelop kind of like the action part, like the second half of this to kind of be specific to those who might just have like quick outreach touches as they're going to health fairs versus going to somebody's like home to have an appointment. But what we found so far, our preliminary like results is that the training, we did a pre-post test to assess the differences in their knowledge about tobacco, their confidence in, discussing tobacco and doing brief counseling, their motivation to do it when they talk to people, their confidence and just in motivational interviewing in general. And we found their, from pre to post, so they got the pre-assessment right before the training started and post-assessment right after it's ended, that there was an increase in all of these aspects. So there was an increase in knowledge and motivation and confidence. But now we're trying to look at the follow-up data of, after 6 months, do they retain the knowledge they learned at our training? And, quick answer is no, not really, which is, kind of expected because a one-time training, like who remembers things like from 6 months ago. But we did find with a small sample that about those at 1 month after the training still had that same knowledge. They still retained the knowledge at 1 month, but it dropped off at 6 months. So now we're trying to think about how do we develop booster sessions into this program? What is the continuous training kind of model going to look like? And then lastly, the sustainment phase is always the hard one. Like how we develop this program, how do you just sustain it? The cost of this program actually is the cost of if you want to, we have a handbook that the CHWs really do like, so they do refer back to it. It's designed that they're individual sheets of paper that you could like copy if you wanted. And we all have this online too. So in case you didn't want to like print off paper. But the cost is the handbook and also just the time of the instructor. So we're like, how do we make this sustainable so that it still is affordable to community health workers, like after, over time. And so we're really thinking about this train the trainer model. So if, we're designing this instructor program for people to come get trained on our program to be able to teach our program in their respective institution. So that cost of like the trainer will be subsumed under there's just like kind of normal job, and then you wouldn't have to have that cost. And that's kind of our idea of kind of thinking about the sustainability of it. And so we're going to develop that now. We've been in the process of working with someone from the University of Arizona who already has an instructor training in tobacco that we're kind of going to take their playbook and try to adapt it to our context here. Because that was like, that's how this program started, it's of the inaccessibility of trainings. And so I want to make sure this training that we created is going to like stay accessible to CHWs. And then this is just a shout out to all of the CHW organizations that we've worked with over the course of this program. And then just to end with this very, very busy slide of, this is, I kind of have two areas of research. Again, like one is trying to still explore and understand health disparities, but understand how psychological, social factors all interact to influence biological mechanisms that, contribute to chronic disease development, cancer specifically. And then I have the intervention side, which I just kind of presented to you of, how do we optimize these community programs? How do we engage with community organizations to really reduce risk in the communities? And this is my busy slide of like all the things I have going on. But I'm not encourage like students in research or anyone else to kind of think about a conceptual model for your research that might be helpful. And this is mine, kind of starting with like, I've always been interested in smoking cessation and obesity because they're linked together. Once you quit smoking, you gain weight just as a byproduct of quitting smoking. But then you also see these rates of obesity increasing over time as smoking rates are declining. So I've always been interested in that. And then interested in, kind of biomarkers, kind of like what leads to incidence of, in this case, cancer or chronic disease. So like inflammation is one of those like mediating pathways. So from that, like all of my projects have been kind of mapped on to like one part of this like conceptual model for me. And it also kind of helps me like stay focused, stay oriented, say no to some things, when people come and ask me to participate. But it's nice because it kind of helps you think about like where are you going with this like research program, what's going on. And then another thing that I am really trying to think about now, based on this community feedback, is this dual use of nicotine and cannabis, because it comes up over and over and over again, and there's like less research on the health effects of that over time. But I think that's it. That's all I have, so I can stop here and stop sharing. I see the chat has things in it. Let's see. I can't find my little. There it is. Okay, and I will open it for questions. Okay, maybe I'll try to read the chat real quick. So the first question I see is about the alcohol use and tobacco. And that's something again I'm kind of starting this area of like the co-use of nicotine and other substances. Because again, this is not, we can't pretend like people are only using tobacco, right? I think that what we need to work on is the research on nicotine and alcohol has really talked about how alcohol enhances the effects of nicotine, like on the brain. So people are more likely, that's what obviously it's harder to quit. People are more likely to have like more of like those like pleasurable feelings, and like they describe it as this kind of like elevating the experience and stuff like that when people are using alcohol. So I know a lot of research has been in the context of how it has been harmful to quitting tobacco, but there still is a whole area that needs to look at the actual health effects of the combined use of those substances. That's a good question. Um, okay, any other questions that anyone has? Or thoughts or comments?
I'll ask one, Marcia. I'm just hi, and thank you for being part of our Research Bites. We really appreciate it. I'm curious, in the slide you shared about the depth of community engagement, I really appreciated that. And, in social work, like public health, that's really, there's a lot of uptake of that. But I've also found that funding sources don't fully appreciate the time and the money that it takes to do the real, Cadillac version. So I
Yes,
see you nodding your head.
yes.
And so how how do you kind of manage this like desire to be at the far end of the, but then sort of there's a pragmatic, you're a junior person, and so
Yeah,
you also have to be present in your own research.
yeah,
So I wonder if you can talk a little bit about like the tension of, wanting to maximize community voice and engagement and all of that,
yeah.
and being at a research institute that is going to want you to kind of be on this other end of
Yes.
of the spectrum, and funding that limits how you manage all that.
Excellent question. I've never thought about this at all. Just kidding. So yes, I I started off with the explicit feedback of like, you can't do this work to get tenure. So that's how I started like my career. Not necessarily from people from here, but like, other places that I
Yeah,
started.
but yes, I'm sure that's the advice. Yes.
And so my strategy was, okay, well, I'm gonna have two separate lines of research. I'm gonna have my, you know, like my tenure research, my traditional epi research,
Mm-hmm.
right? Which I still love to do, right? I do like to do that research. And then I'll do this. And when I started this project, I committed to myself. I said, um, I am going to do this well. And so I was like, so therefore, I did see it as a long-term thing. So everything that I do on this project is not like an end goal to like finish this
Mm-hmm.
grant or to do this. It's just like I see it as this like kind of, I don't know, this is like car that's running and I'm just trying to make sure I have like the road built in front of it so it can keep running forward, right? And that's how I see the funding sources for that. So therefore, I've been very flexible. I do have a great chair here in public health sciences where, she was just
Mm-hmm.
like, think about what you want to do and find the money to support that. Don't think about chasing the
Mm-hmm.
grant and
Chasing
getting the
money.
grant
Yeah.
because then you're gonna have to do whatever the grant says, right? And so and I took that to heart. So like I've
Yeah.
been doing a lot of like pilot, funding. I actually got a grant from the CDPH because they
Mm-hmm.
wanted me to train their CHWs, and I was like, well, I also want to do this research, and they're like, okay, great, we'll
Mm-hmm.
give you money, for this or whatever.
That's
And
great.
so I've been thinking about it as like piecing it together. And I have not
Mm-hmm.
gotten a one big grant from this work yet. And I don't even know
Mm-hmm.
if I will or not, but I've
Yeah.
been kind of
Yeah.
thinking about like putting the pieces together. But that being said, I've been spending a lot of time on this work. And that's where I've been getting all of my talks from. People have wanted to like hear about this and contracted me to
Mm-hmm.
train and everything like that. And so I've been spending my time on this instead of my like tenure getting, you know, research, but it is hard. And I think that like you do have
Yeah.
to kind of make a commitment that you're gonna do the work well in the beginning.
Mm-hmm.
Because otherwise you will just like fall into that trap of just and
Yep.
also I think the other important thing too is like community engaged work is rigorous research, right? And I think it's this idea that people pretend like it's not. And
Yep.
I do a lot of like, fighting back of those ideas. Like when I present this at like conferences, I'm like, this is what we need to be doing. We like it,
Yes.
it's more rigorous to talk to community
Yes.
members than it is to not, right? And so I've had to, argue with reviewers and stuff like that, but
Mm-hmm.
I've made it a point to publish all of these things along the way. So I published like the needs assessment. I published like the second focus group. I published a full qualitative paper. Just like
Mm-hmm.
I published those pieces along the way to show that this is work that needs to be disseminated and needs to be published and things like that. Instead of kind of waiting until like my big, once I collected all of my data, like kind of how we're
Yes.
used to, right? And so like
Yes.
I published preliminary on like the 70 people that we collected so far, and then I'm going to do another project that's going to be on all of the so like I think like treating it like what it is, which is rigorous work, is also very important in this
Mm-hmm.
place. Okay, I'm gonna stop talking because I can just
Thank you.
like harp on
Thank
that
you.
for a
Thank
while.
you.
Yeah. Yes, Tracy. Oh,
Hey, thank you so much for your talk. I don't really have a question, but I just wanted to give a testimony,
yeah,
and to out myself as a former smoker, and to say thank you for doing this work because it's so important. And it took me to having a near-death experience to be able to quit smoking. I started smoking in high school. I grew up in a household with two parents who smoked. And even as a kid, I would try to hide their cigarettes, and then I turned out to be, ended up being a smoker myself. So it's a very difficult and challenging addiction to break. And it took me I tried many times in different ways. So thank you so much for this important work. That's
yeah,
that's the main thing. And then the other question I had was like, I have friends who are still smokers, and they tell me stories about talking to their primary care physicians and, them saying, well, what's most important is that you lose this weight. The smoking's not that bad. It's just like telling
Yeah.
them crazy stuff or saying you have to quit smoking, but not giving them any tools.
Yeah.
So I'm wondering, like, in terms of kind of like, how do you impact education for you have the community health
Yeah.
workers, which are key, but also people going to primary care physicians who have no training or no whatever on how to address the whole person and all, their all parts of their bodies and their behaviors.
Yeah. No, I agree. Like that is the tough part. Like, there's research on that of like people saying, okay, well, we need to focus on this immediate, health thing and smoking is whatever, whatever, whatever. But I think that is, I've been obviously working with community health workers, but like, there still is a lot of work to do at the provider side. And again, I think I think this is happening again because we don't talk about that. And like now the new thing is obesity, right? And like public health or whatever. And I think that's the problem is that we kind of shift our attention. And so people don't see it as an immediate threat anymore. And that's just not the case. And so we can do better, I think, in public health as well, because we kind of like move on to the next things, you know what I mean? But to your point about how difficult it is, it's the nicotine addiction. Safest chemical in the cigarette, nicotine, only chemical that makes you addicted. All the other chemicals are designed to get nicotine to your brain faster. But we also think about the addiction as not just biological, but also psychological, like the habit that you develop, and also social. Think about your social groups, your family, the people you're around. So when people try to quit smoking and not address all three of those components, that's when it's hard. I also always recommend the quit line, the state quit line, because they have resources that can give people nicotine replacement therapy and other medications. And there's counselors that can, talk to, whomever. I always recommend that as a free resource for people if they really want to just get started thinking about quitting. Thank you. Okay. Oh, questions in the chat. Okay. Tracks on DFI's use of medication, struggle with like. The question about naltrexone and smoking cessation, do you advise the use of medication for individuals who struggle with breaking the habit addiction? It's always been interesting with cigarettes and other drugs or other like, people call harder drugs or illicit drugs. Because oftentimes people will, again, kind of put the cigarettes on the back burner as in like focusing on like the other addictions too. And then like it's not a bad approach, but the problem is that, people are left with still their nicotine addiction after that. And so I don't see too much research about the dual like quitting interventions or trying to interventions or quitting like more than one. Like oftentimes people will say they need to focus on one, they need to focus on like the harder drugs. Um, but as far as medications, I can speak on medications for nicotine addiction. Varenicline, which is like the medication that is like, the smoking cessation medication, has been proven to be like the most effective medication, period, just by itself to help people quit smoking. That's something that you have to get a prescription for from your doctor, but the idea is that it's designed to you're designed to start taking it before you officially quit. And the idea is that you're kind of developing a different association with smoking. So it kind of like, smoking becomes like people kind of start to feel sick if they like, smoke and like have nicotine in their systems and stuff like that. And it's kind of developing this negative association with smoking, but that has been proven to be the most effective. Nicotine replacement therapy plus counseling or talking to somebody to help like identify triggers and get through those cravings is also as equally effective as taking the varenicline. So I just want to, say that out there. Okay. Does your work include structuring the introduction or modeling of alternative coping practices to the intervention violations to think about towards mental health and behavioral? Yes. Which is something such as smoking marijuana? Yes. So our program, we're thinking about we've gotten this feedback a lot, and we're thinking about having kind of like specific modules for specific groups of people. So like having like a mental health module for those who have other mental health disorders, having a substance use model. So for other module for of those having other substance uses. using other substances too. And what we do, and a general thing in our program, is talk a lot. We have a whole section on mental health and smoking and stress and smoking. And so we do a lot of teaching of like deep breathing and like stress reduction like techniques like during our general one, but we are going to try to expand and think about the context of people using those other substances too. But not, we haven't gotten there yet, but that's something we have been thinking about. All right, interesting. It seems like a very buzzy topic at the moment. I wonder if there's been an increase in funding available for research in this area. Is the question about research in weight management? Whoever asked this question. It says you mentioned interest in weight management, which seems like a very buzzy topic at the moment. I'm wondering if there's been an increase in funding available for research in this area. I think I've tended to see more research in obesity than tobacco, and I think we're like in the tobacco world, the cancer field really cares about tobacco, and so a lot of the funding for tobacco has come from cancer. But in general, as think about like behaviors and things like that, I think obesity is more like of the talk. And then I think now we also are kind of moving a lot. Some of us, like I have a trainee who's really thinking about weight stigma and like centralizing weight in kind of healthcare and stuff like that, and the utility of that, or how it's maybe not useful because of the weight stigma and stuff like that. So I think people are, in the obesity world, are really kind of thinking about how are we thinking about this, and how is it important? How is talking about weight and thinking about losing weight important? Helpful to understand accessible everyone. Acupuncture for smoking cessation, yeah, that's been tested a little bit. There's less evidence like as a whole, like review articles and meta-analysis to show the effectiveness of it, but there are studies out there that shown acupuncture is helpful. Okay, let's see what else am I? It's so hard for me to like read the chat. Okay, okay. The Bronx and Black Panthers boards so third there from heroin. Okay. Thank you, Mercedes, for that. Oh yeah, the GLP-1. I'm not well versed in that research, but I know that is just a hot topic right now. My primary care fellow, who's my trainee, she's actually working on doing a community health worker intervention for, weight stigma and how to discuss weight, because many CHWs will, like in diabetes prevention, talking about weight loss and things like that. But she is very adamant about like the GLP-1 not being accessible. So what if we find this like miracle cure and like this is great, it's like not going to be accessible to people, and like she's very adamant about discussing that as we're talking about these interventions. Okay, oh, we're at the hour, so any final thoughts? You can always email me. Any questions? I'm usually on campus if you want to chat or meet me ever.
Thank you so much for joining us today, everybody. The talk will be available. Thanks so much again.
Thank you. Bye, everyone.